We're back with Dr. Hamill. Hamill's completed many of these cases. Dr. Hamill is he's in Ireland. He travels around Ireland and UK, teaching other doctors the CHROME process, the fundamentals of it, but also teaching them in under 2 hours. And the last podcast we dropped off at abutments, and we were going to pick up Temp Copings.
Yep.
I can let you take it away with what you do for Temp Copings. I got tips too, but your fundamentals of the copings.
So for Temp Copings, get them out, get them lined up, have all the screws in them, have everything organized, and have them close at hand. And it's pretty simple for me. I start with the straights. So anything with a straight abutment on, I will just put all the temporary copings on those implants, and that's number one. Then I check my provisional over the top. And 99% with CHROME, the provisional will just slip over the top without any touching or any impingement of the temporary cylinder. So I do that as my first step. Then I put the temporary cylinders on each of the angled abutments one at a time. Check the provisional. Next one, check the provisional. Now, if any of those are impinging, we then got a decision to make. At least, first of all, we know which one's impinging, because if you put them all on at the same time, then go to put your provisional on, it's almost impossible to work out which one's in the way. I've been there, I've adjusted the bridge, and actually you realize, you're adjusting the wrong one. So we want to keep adjustments to a minimum. And actually, using this technique, you probably don't really have to adjust the bridge at all if you've been careful during all the other steps. So straights on, then angles one at a time. And if one of them is impinging, then we're going to decide, do we adjust the bridge? So that's the first thing. Are we happy to do that? Or secondly, we have to go back a step and we have to check the rotation of our implant, because it'll be the rotation of the implant that's throwing out the temporary cylinder. So if it's a lot, and it may be because you have a rotation problem, it's worthwhile going back, just popping back on your carrier guide, or your carrier guide's on, just checking where that occlusal or the screw that's holding your multi-unit abutment, is it lined up with the black notch? If it's not absolutely at the black notch, you've got a rotation problem. You've not got a bridge fit problem. So I would then take that multi-unit off and I would very slightly rotate that implant. Okay. In fact, I've even gone back to putting the osteotomy guide on and checking it with the notch, or checking it with the little nodule on the guide.
Yeah.
So you might have to go all the way back to there, but it's going to save you time in the long run. So once I'm happy with the rotation, then I go back, temporary cylinder back on, and the bridge should theoretically go on. The only other thing that's a problem is if you've placed your implant too deep or it's not deep enough, then that will throw your temporary. So those will be things you want to check. So once I've then got all the angles on and I'm happy, then again, it's just temporary bridge comes off, rubber dam. Again, have your rubber dam laid out in front of you, and it's just, I use a set of tweezers, one on, stretch the rubber dam slightly, pop it over the temporary cylinder and let it go, and it generally nips down into the right place. Then I put the bridge on, and then I put the blue plugs on. And again, as the blue plugs, I'll have my nurse hold them all, generally line them up between her fingers here, and I just lift one, pop it on, next one, and nice and speedy. So you're not going looking for stuff. Then we do the pickup. You taught me in the pickup. I used to do it individually, or I do two and then hear them, but you don't like that at all.
No, not at all.
I gloop them all is what you told me to do.
Do them all.
So we do that, cure it, and then we just repeat for the rapid.
Yeah. And the reason for the luting is if you cement one and then lute it, and then the prosthetic moves a little bit because it's manually being held down, then you instill tension in that implant.
Yeah, totally get it. And that was something that I hadn't really thought about, I have to say.
Yeah.
But I do them all now in one go.
Yesterday, the team used long screws instead of blue plugs.
Yes.
I thought that was a good idea. One problem is they put too much stellar material up and around the screws, so I had to dig a couple of them out. Yeah. But otherwise, just some what do you call them? tweezers or something a little bit stronger, you pull them right out. That worked really well.
Yeah.
Because then you, first of all, you don't have to take the time with the blue plugs, and you don't have to mess around with little screws.
Yes. Yeah.
Because what, like
well, I was on a case yesterday with a chap who was observing, a very, very experienced full arch surgeon who was looking at chrome for his practice. And it was one of the things that he said, long screws would probably save a little bit of hassle. And again, it was something I hadn't really thought about, but I'm going to give it a go, I think.
Yeah, well, most systems don't come with long screws. They come with the little screws for the temp copings. You know, we were working with Megagen yesterday, and they have this lovely kit with all the parts in it, and they have long screws, but you'd want to order some long screws, like open tray impression screws. Yeah. And then just keep them and then use them as a tool.
Reuse them.
If you know, most are going to be using short screws, and how you said you take out all the temp copings and line them up, put the screws in them, and then have at least 2, if not 3 screwdrivers.
Yeah.
Because you put a screwdriver in the coping, into the screw, hand it to the doctor, and that thing goes in the mouth, and you will save yourself 10 minutes. All kidding aside, it'll be 10 minutes of fussing around with undoing packages and finding screws and dropping them on the floor. It's critical, I think. We do it every time.
And it's frustrating. It's frustrating when you're sitting there and you've put one temporary coping in and you're waiting for the next one.
Yeah.
And the packets can be difficult to open. And then, as you say, a screw, because somebody's panicking, the screw pings on the floor. And then it's just, that could take 5 minutes to find the screw. So.
Yeah. And you could even put them on you could soak them in some liquid, you know, while you're waiting for that part to happen. I mean, you could take them out at the beginning of the surgery and have them on a tray ready to go. Like yesterday, we even put the blue gaskets on the temp coping, screw in the coping, screwdriver in the, and they were long screws. So we had to use a really short driver, you know, but most of the time it's going to be a long screw. So you could have the temp coping, the screw, the blue gasket, and the driver all as an assembly, handing it to the doctor and screw it in.
Yeah, you could. And then as once you've done I picked the provisional up first, and then I picked the rapid up. That's the technique that I use. And it's just, it's about having it. So whenever the provisional comes out, I hand that to the nurse. She is then taking the rubber dams off, relaying the rubber dam out, and then by that stage, the blue plugs are already laid out. And I do that on the patient chest. Some people don't like doing that, but if you have a table that comes over the top, that's fine. But just lay them out in a row. And then you're just, as soon as that happens, then it's another set of temporary copings on. You know, if you've had to adjust anything, you've also adjusted the rapid, but that doesn't happen very often. Then you pop that over the top, rubber dams, pop it over the top, blue plugs, exactly the same procedure. It's repeat and rinse. And it's being organized. That is the absolute key bit to it.
So in the surgeries I've been on, I find that we're adjusting rapid appliances probably more often than you are. And it could be because I go to a lot of different surgeries, a lot of different kits, but we're almost always adjusting it. And so we end up doing the rapid first, so we know where to adjust on the take-home prosthetic.
Wow.
So most of the cases we do are C2F, you know, so we don't even pick up the prosthetic. But when you pick up both, like if I have to adjust the rapid, then I also adjust the take-home prosthetic at the same time, or if it's extensive, then. But one thing you mentioned about the procedure of putting the copings in, I agree for sure. Put them in the straights first. But what you find in a lot of these cases is that straight doesn't necessarily mean parallel.
No, correct.
Because you end up with flared out implants, because that's just how the bone structure is. You know, you don't, And so what I found is that when you know, and just as a note on the surgery mat, we just added that image that you saw. So you'll see the carrier guide, and you'll see all the temp copings as planned as an image now. Yeah. And so when you look up at the surgery mat, you'll look at the mouth, you'll see, oh, you know, this one is straight. It's a straight coping, straight MUA, but it's not parallel because that's just what the bone gave us. And so on these cases, which is very often, we'll leave this screw loose, and we can leave it very loose, and then it will bend over. You have a draw, prosthetic drops in, and then you tighten it down.
Okay.
That's a neat trick. Sometimes we leave 3 or 4 of them loose, and then you just kind of wiggle them and push them into the prosthetic so that you're not stuck with, they're all straight, but they're all
Yes.
like this.
Yeah.
They're all flared out.
The other thing I think, Alan, to point out is you go right back to the planning meeting, is looking at the draw at that time and spending a little bit of time with the planner to think forward to here.
Yep.
I'm going to pick up this prosthetic. I want my draw as good as I possibly can get it. And that's one of the things that I do with the planners whenever I do my cases, is that I look at that draw. And so I have to say, I adjust almost no bridges.
Yeah.
Because we spend the time saying, well, I want this draw to be as parallel as I can. We usually do it in pairs. So if there's 2 distals and they're angulated, we're going to pair them up. And then we pair the anterior straights if they're all straights. So we try and do it in pairs. And that way, definitely, I think it saves you time when you come to this pickup bit.
So a lot of this stuff goes back to the plan.
Yeah.
And we have the ability to put all the abutments. We have the ability the computer to align implants together for all the straights. So we can control this either visually or through, the wave of a mouse. But the other thing is, and I noticed you did this on your surgery, that it kind of goes back to videos ago. But when you're planning, try to plan as many implant sizes, widths and lengths as you can the same.
Yes.
Because that way you're limited to the number of drills that you're going to use and the speed of doing it. So that a couple of those, I think you learn that after doing a lot of guided surgery, that you have ultimate control over what implants you take, and you have control over your parallelism of the temp coping. So the planning is just really key to that. Yeah, really good point. And then another thing about temp copings, sometimes even though it looks like it's not parallel in the mouth, you look on the screen and it's planned that way. Kind of mentioned that before, but that's not a matter of rotating an abutment or too deep or shallow. It's just planned there. And so on those cases, pick up the ones that you can, and then go back and pick up the ones that are off angle that you just can't see. Because remember, the holes in the prosthetic are following those temp copings. Yeah. It's not like the holes this way and the copings are this way. You can look down the prosthetic and go, oh, these are flared. And then you can drop them in from the occlusal.
Yes.
Or you can come back and pick them up one at a time later, or 2 at a time later.
Absolutely. Yeah. We go back to the point we made, problem solving and engaging your brain. When something doesn't seem right, you have to go back and think, well, actually, is this how it has been planned? Rather, we're very quick, I think, as dentists to lift a drill or lift something to change it because we can. But actually, let's go back and look. What is our plan? What does our surgery mat tell us? Was this to be expected? And it's better not to grind out the facial wall of a prosthetic simply because it was a misreading of what the plan was. Yeah, absolutely. Or your angulation was slightly out, or your rotation, was slightly out on your implant. You're so much better to go back to that step and check than grind your prosthetic. Because if your prosthetic is weakened and it breaks, that is going to cost you a hell of a lot more time than it did to go back and check. Right. Which is going to happen when you weaken it. Yeah. So that's the copings. And then the prosthetic pickup, just the fundamentals of it. We really recommend this stellar material. Because you don't need an adhesive or a bonding agent. Brilliant. You just squirt it in. It's hydrophilic, and the mouth is always wet with something. But I noticed that sometimes people don't inject enough material, but then sometimes they over-inject. It's usually one or the other. If you over-inject, then you end up having to grind all that acrylic off when you're back doing your conversion. Yes. And if you underdo it, you risk leaving a coping behind or it falling out. And then the metal is out, the carrier guide's out, you have no reference anymore. So you have to find it right, right in the middle. You want the tip about halfway down. Correct. Yeah. About halfway. And then you don't backfill. And then backfill. As I say to everyone, you're going to inject, you're not squeezing the life out of the thing. you're really, what's what I do is put the tip down about 50%, exactly as you've said. And as soon as I can start to see the pink material, and I start to withdraw the tip.
Okay.
Rather than holding the tip in and squeezing too hard. And then I think it's also important, as you said, not to overfill the top of the blue plug, because you then have to cut that back out again.
Every time.
Which is just a pain. There's no need for it.
No need for it. Yep.
So you're absolutely right. That nice steady draw the tip back out, that will make sure you get enough material around your temporary coping.
Let me mention one more thing about the copings and the prosthetic pickup. Often, the team will force the carrier guide down, and the tissue's in the way and the bone's in the way. So usually the tissue, and you end up with a carrier guide that's got a little bit of a bow to it. Yeah. Which is bad. We had that yesterday, but we spent so much time with the patient had a cleft palate. So it was a really challenge with the folds of tissue in that one area. So we decided we were going to just stop messing with tissue, and we were going to let it have a little bit of a bow and then force it down with the prosthetic. But the point of saying that is that when you pick up the prosthetic, you have to reflect the lips back, and you have to see that prosthetic is intimately sitting with the carrier guide, that there is no gap, because if there's a gap, then you have occlusion problems.
Totally.
So over force it, force that down to the carrier guide. You can't do any damage. You just force it down until it's sealed, hold it firmly in place while you're luting. I think that's really important too. Yeah, and I think I remember you telling me again, some of these things are things that you've told me a while ago, is that to keep that even pressure on the provisional bridge when you're luting. So usually I will get the nurse to do that. Depends who I'm working with sometimes, but it's just to say, you hold it, you don't let go until I tell you to let go. But because, as you say, the pressure can vary. They can push harder on one side than the other. If your carrier guide isn't sitting fully passive, then you will bring in problems. There's no doubt. Yeah, it'll move, and a half cured stellar will shift, and it will deteriorate the quality of that bond considerably. It's somehow it's just changed the, that material. You will not get the same kind of bond if you have movement. No, listen, and stellar's a great material, Alan. Absolutely. For me, that was a big jump forward in terms of problems with things not luting correctly or not luting well enough. It sticks really well, and you just don't get problems with it. Yeah, and I always wait 2 minutes. I know it's a 5-second tack, it's a 20-second full cure. But always wait the 2 minutes, set the timer, and then you will always have it set. That's another, we talk about always. That's an always. Yeah. Wait the 2 minutes, use the light, because then you have it set. You don't have to worry about movement anymore, but wait the full 2 minutes. Okay. Sure. Yeah, because it's a 120 set, isn't it? 120-second full 120. Set. Yeah. Okay. Okay. Well, thank you. Thank you. Tune in, audience, for the final one. We have one more to go. And see you then.